Welcome everyone, this is Yasser Wasifi from Learn Dental Series. It's a great pleasure to meet you again in this episode as we will continue our discussion about diagnosis and treatment planning in operative dentistry. First of all, I would like to declare that I don't receive fees, compensation or royalties from the sales of any of the products shown in this discussion. Also, I have no any conflict of interest with any of the discussed products or techniques. This presentation has not been sponsored by any company, agency or organization and is only prepared for educational purposes. This presentation is also copyright protected and could not be transmitted by any means unless you have a written permission from the author. Today we will continue to properly diagnose and evaluate existing restorations, as we already finished how to diagnose a freshly created or a freshly introduced carious lesion at different levels, early and late stages. In part 1, we already discussed patient assessment in terms of demographic data, chief complaint and its history, medical and dental history. Then we are going forward for clinical examination and diagnosis, starting with examination of dental caries at different levels, traditional level, then advanced level, then caries risk assessment. In this episode, we will discuss how to examine an existing restoration. Let us start with examination of existing restoration, and we will start with amalgam restoration, then followed by tooth-colored restoration and indirect restoration. Amalgam as being the most commonly used and still used up till now, or the most commonly restoration you could find in patient mouths. Amalgam restoration should be examined for 10 issues or 10 problems that may arise, okay, or you may clinically find one of these or two of these clinical problems, especially those amalgams made by manual techniques of manipulation, especially proportioning and manual trituration, where we could expect excessive mercury, residual mercury in our content of the final amalgam restoration. These 10 problems that may be found, including amalgam blues and tattoos, fracture lines, marginal ditching, voids, overhangs, improper anatomical contour, improper proximal contact, improper occlusal contact, marginal ridge incompatibility, recurrent caries. Please, I would like to remind you about certain characters and certain features of amalgam restoration that should be considered while we are examining existing amalgam restoration. Still up till now, amalgam is one of the best adaptive restorative material to cavity walls and margins, as being direct restoration, as being inserted into its plastic phase inside the cavity. Although we have a limited working time, but still you have enough time to condense the material under force while it is in its plastic phase and taking the shape of the cavity with maximum adaptation to cavity walls and margins. Okay. Also, if amalgam is properly manipulated, then you will have a slight microscopic setting expansion by times that will increase its adaptation. Also, although flow and creep is a major disadvantage of amalgam that may lead to loss of anatomical form, but still it moves your restoration as a time-dependent flow and creep, okay, towards a margin that increases its adaptation. Again, tarnish and corrosion of amalgam is considered as a major pitfall, okay, but at the same time it improves the sealing ability to cavity walls of amalgam restoration. That's why when you have an old amalgam restoration as old as 20 or 30 years, it will be a great problem when you are trying to remove it, and sometimes the corrosive products staining the dentine that needs to be managed. And as we discussed before, under radiographic examination, that you may notice under old amalgam restoration a radio opaque band denoting penetration of tarnish and corrosion products and then contents into the dentinal tubules. All of these should be considered. At the same time, you should remember that amalgam is a multi-phase heterogeneous material, and this leads to its brittleness. It is a brittle material that easily broken under tensile stresses, especially if you don't have sufficient bulk. It gains its resistance as a bulk resistance material. At least 2 mm bulk should be available to withstand the tensile component of occlusal loading force. Also, being flowable material or being suffer from creep and flow, this lessens the ability of amalgam to preserve the anatomical form which is carved in the first time or the first week. Okay, you carved your amalgam. Amalgam lost its anatomical form due to flow and creep, and that's why its use is limited to certain cavities with certain extensions in closing open proximal contacts. Okay. Also, you should consider all of these. Okay. Let us go for amalgam blues. What is amalgam blues or amalgam tattoos? It's a leaching out of corrosive products of amalgam into dentinal tubules or into the gingival tissues as tattoos. Okay. This discoloration, which is seen through enamel, okay, tends to be bluish discoloration, is due to, as we mentioned, leaching out of corrosive products of amalgam into the dentinal tubules and seen through very thin enamel margins or undermined cusp or marginal ridges. Okay. Although the amalgam at this time will be absolutely sound, sometimes the main problem of your patient is only aesthetic. That's why it is not considered as defective restoration unless the patient is suffering from aesthetics. Okay. That's why its management is elective. It depends according to patient needs. Okay, if he is in need to replace it or not. Although this amalgam blues indicating leaching out and corrosion, but at the same time it indicates maximum adaptation due to sealing ability of these corrosive products that seals amalgam with dentine wall. Okay, sometimes in cases with gingival extension, either buccal or lingual, and the amalgam is manipulated manually, including proportioning, including trituration. Those are the mechanical part of manipulation and could be manual. Otherwise, all steps are performed manually by the operator himself. We don't have robots to condense amalgam or to carve amalgam. Okay, then there will be a great ability for tarnish and corrosion due to increased residual mercury content that will drive the leached corrosive products to go for the soft tissues. Okay, and is shown as amalgam tattoo. It's the same idea, but for the soft tissue it is tattoo, for the hard tissue it is blues. These photographs showing, number one, this is an amalgam blue shown through weak cusp, okay, that shows undermined enamel, transparent enamel with maximum corrosive products. The other one is amalgam tattoo, as this cavity is occlusodistal cavity and it seems the hidden part, okay, it seems to have an overextended subgingival amalgam, okay, and this case showing both amalgam blues and at the same time amalgam tattoo. Again, unless the patient is in need to improve his aesthetic, okay, then you are not in need to replace your amalgam. In general, already manual amalgam proportioning and trituration is extremely limited or nearly nil nowadays, okay, and all the amalgam available either for safety procedures from the risk of free mercury or whatever the cause, it is available in a form of capsules, which is more easy and more convenient and more safe when you are using amalgam restoration. That's why your proportions are much more adjusted. Corrosive products are lesser than manually triturated or manually proportioned amalgam restoration. That's why it's nowadays it's very rare to notice amalgam blues or amalgam tattoos. Then comes fracture lines. Fracture lines could be diagnosed visually or tactile or by using microscope. And the most common area always is the isthmus portion. As you remember from the cavity preparation of amalgam restoration, this is a critical area. And you should narrow it to be within 1/4 to 1/3 of the intercuspal distance between the buccal and lingual cusps at the proximal area. Okay, why this area is critical? Because of the reduced thickness of amalgam, because from occlusal surface it is carved into fossa, triangular fossa, and at the same time you have in most cases sharp axopalpal line angle, and that's why your amalgam with reduced bulk is scissored or cut by what is like a scissor, a cusp from the opposing tooth and a sharp line angle from the internals of the cavities that may maximize the possibility of isthmus fracture of amalgam restoration. That's why to prevent it, you should round the axopalpal line angle and slant it towards the pulpal direction, or have a slight occlusal convergency, okay, to be more converge internally, or to be slanted towards the pulpal a little bit to drive your sharp axopalpal line angle away from the triangular fossa area and away from the reduced thickness of amalgam. Okay, that's why it could be visually examined or tactile examination with sharp explorer, okay, or by using any magnification, including loops or including microscopes. Okay, you will find a line mostly at the isthmus portion for compound cavities, and this indicated total replacement. No way you should replace your amalgam restoration. Then comes marginal ditching or marginal degradation. Okay, it's a fracture or crevasing at the tooth restoration interface. Okay, it takes the shape of V-shaped notch or V-shaped crevice. Okay, this crevice is always created due to improper cavo-surface margin inclination. Either it is acute angle that leaves undermined enamel that will fracture, okay, not the amalgam is fractured at this time, or it is obtuse angle much more than 90, which leads to amalgam covering a beveled tooth structure or a slightly beveled tooth structure, and amalgam at these margins having no bulk that lead to also this V-shaped fracture. It could be diagnosed by visual examination when it is too large, okay, or may be diagnosed by tactile sensation using sharp explorer, okay, that will drop at tooth restoration interface. Okay, the management, there we have two options for management. Either it is shallow ditch or it is a deep ditch. Shallow ditch, it is less than 0.5 millimeter, okay, in deep, does not necessitate repair or replacement, just margination and finishing, okay, of amalgam restoration at this margin, and it will self-seal, okay. That's what they thought, okay, as amalgam being self-sealing material due to tarnish and corrosion products, okay. For me, I didn't prefer this solution. I prefer always to replace amalgam, okay, because it's a relative term how you could measure 0.5 millimeter tips of this ditch, okay. Just for me, if it is unnoticeable, if it is just filled by explorer, I'm trying to finish and polish my amalgam restoration and trying to re-examine it under magnification and re-examine it under using sharp explorer without any pressure. Take care not to force your explorer at the margin. It will actually produce marginal ditching. If it is not present, it will be present, okay. And at this time, after trying this, I will re-examine it. If I am satisfied, it's okay. If I'm not satisfied, I will replace amalgam again, either by another amalgam or by any other restoration. But it shouldn't be presence of any ditch. Your restoration, either amalgam or whatever your restoration, should be flushed with your cavity walls and margins. Okay, deep ditch, it will be obvious either by naked eye or felt exactly, you could not miss it. Okay, and it will jeopardize the integrity of marginal adaptation of your restoration, and your restoration is considered as defective that should be replaced immediately. Sometimes you didn't feel, or you may miss the diagnosis of these marginal digits. Please refer to the patient history during the follow-up visits. Okay, ask him about the restoration, or ask him if the margins catching any fibrous food or not. Okay, that also either indicates marginal flashes or marginal ditching. And by the way, marginal flashes will also by time will result in marginal ditching, as it is a flash and have no thickness and it will break down. Those are pictures of amalgam with gross ditching at the margins. These gross ditching, okay, either appears immediate in the second visit, okay, or at the same visit if you are working beyond your working time and your amalgam, you are insisting to carve your amalgam while it undergoes initial sitting, okay. Those are old restorations showing marginal ditching. It is obvious that there was multiple flashes that was broke down or improperly carved restoration. The operator didn't reproduce the anatomical form exactly, leaving too much flashes, okay, and the margins are invaded by recurrent caries. Then comes voids. Voids are mostly localized, okay, not at the margin. If it is at the margin, it is considered at the tooth restoration margin, it is considered as a ditch, or it doesn't matter if it is originally void or ditch, it's a defective margin, defect in adaptation. These voids, mostly due to improper condensation between each increment and the other of amalgam, okay, or sometimes the operator doesn't use the incremental condensation technique. He backs the amalgam as a whole, okay, and trying to condense it, okay, and still there will be voids at the bulk surface of amalgam restoration. And sometimes it may be also due to delayed carving. You are carving amalgam while starts its sitting, and amalgam is going for sitting, and you finished all the allowed time during the working time of your amalgam, okay. At the same time, okay, with the same manner, if the void is at least 0.3 millimeter deep and is not located near to the gingival 1/3 of the restoration, so you could finish and polish your restoration and you will get rid of these voids. If the voids are at margin or near to the gingival area, you should replace your amalgam. For me, if the voids that appears as surface irregularities, okay, at occlusal surface, I will try to finish and polish my amalgam and just inspect the result, okay, and re-examine my amalgam restoration, okay. If it is still rough surface, if it is still roughness after I finished and polished this, it is considered as major voids, okay, that by time will lead to stress concentration, and underneath this void, amalgam lost bulk thickness resistance, and it will fracture, okay, but it's a matter of time. At the same time, this void, okay, will result in a rough amalgam surface, okay, that will attract food debris, and by time it will result in recurrent caries. So when you discover voids or the patient give you a signs of food accumulation at the surface of your amalgam, either interproximal or at the occlusal, I think it is better to replace your restoration. This is the human rights, okay, who forces us to deliver a high performance restoration, because your patients deserves this and deserves much more than this, okay. Those are amalgam voids, okay, at the surface and at the margin, okay. Also, don't forget that, I forget to mention that when we are using zinc-containing amalgam restoration, accompanied by manual proportioning and manual trituration, okay, in a field which is not properly isolated, you should expect these voids as a mean of reaction of the zinc or contaminated zinc-containing amalgam. What is commonly found is overhangs restoration, which is commonly at the proximal gingival floors or at any gingival floors of compound cavities of either proximal or buccal or lingual. Okay, this by time interfere with proper prophylaxis measure done by the patient, because it will attract and stagnate food debris, especially when it is at the proximal area. A great percentage of recurrent cases of occlusomesial or occlusodistal, in general occlusoproximal amalgam restoration, also the same for composite, but it is much more frequent with amalgam restoration, okay, is the proximal overhangs. Those proximal overhangs is considered as a major defect that you should replace your amalgam, okay. These overhangs mainly due to the condensation procedure, including improper selection of matrix, improper application of matrix, improper wedging of matrix, or extra forcing, excessive, unreliable forcing. It's not wrestling. You are not playing wrestling with your amalgam increment at the gingival floor that forces amalgam beyond the gingival floor. Okay, these overhangs could be diagnosed visually if it is buccal or lingual, and sometimes occlusal, could be examined and discovered by tactile, by explorer in the buccal and lingual, and the most common is threatening of the dental floss when it is passed deep subgingival, but the most accurate is the bite wing radiograph. Those are bite wing radiographs showing in figures A and B a huge overhanged margin. You could note it, okay, between the upper second premolar and the upper first molar, okay, and you could note it at figure B, okay. It seems to have improper application of matrix, while in figure C and D you could note the accuracy of the lower molar in figure C, and in the upper molars in figure D, the accuracy of applying matrix and wedges, okay. How is the condensation force that adapts amalgam at the gingival floor, but at the same time never force amalgam beyond the matrix you applied. Okay, if you discovered an overhanged margins, you could discover it from the history of your patient, even who's suffering from amalgam restoration that impacted food debris, especially fibrous food, deep subgingival. You could expect that there is an overhanged margin. Then comes improper anatomical contour. When you are restoring buccal and lingual contours, you should reformulate it exactly as it was before you started. Okay, you should duplicate the normal anatomical contours of the tooth, because in its location and in its convexity, it plays a major role in preserving the health integrity of the gingival tissues. It should allow the deflection of your food at the buccal and lingual surfaces with a steady force that stimulates circulation rather than traumatize the gingival tissues. If you reformulate it in a flat pattern, then your food will be displaced or deflected, okay, with its full force to hit your gingiva, the free gingival margin, leading to a great trauma that will result in bite times, that will result in gingival recession. Okay, if you are over bulging it, that means that it is undercarved and lifted. Over contoured bulging, it will deflect the food outside or away from your gingival margin. That will lead to food accumulation within the vestibule. At the same time, you will deny your gingival tissues from the healthy massage that improves the circulation. That's why over contouring, okay, either proximal or buccal and lingual, is important because it will allow a great shelter for plaque accumulation, plaque trapping, and at the same time it will endanger the health of your tissues. If it is undercarved and it is over contoured and bulging, it's much easier to correct it by finishing and polishing and reproduce or duplicate the normal anatomy. But if it is overcarved and under contoured, it is a flat contour, I think it is a must. You should replace your amalgam restoration because amalgam could not accept the addition and the correction after setting. The same for glass ionomer, the same for composite resins, the same for inlays, okay, and all types of restoration. Okay, this is a case showing how much the amalgam is undergoing corrosion near to the gingival tissues because of improper anatomical contours that leads to or gives a greater chance for plaque to be accumulated, okay, and at this time the amalgam is undergoing tarnish and corrosion. At the same time, you are endangering the tissues, as you could see a very red cooler margin from the gingival tissues that indicates it is undergoing inflammatory procedure. And those are schematic diagrams showing you what if you are over contouring it, okay, then your food bolus will be deflected away from your gingiva, or it is flat over contoured, okay, due to under contour due to over carving, then it will hit your gingiva, causing traumatized damage to your gingiva. What is better is to be duplicated exactly that with run along your gingival tissues with a steady force that motivates circulation and enhance the general health of your gingival tissues. Then comes the proximal contact, which is a very important area, or a very important and a tricky area in reproduction, and needs much more training and much more skill of your operator. Contact area should be reproduced exactly the same in its position, okay, and in its dimensions. The proximal area is classified into two anatomical characteristics: and maximum height of convexity, which is reproduced by the proximal contact, which is in the middle occlusobuccal third, okay, and represented by area to the middle occlusobuccal third of the proximal surface, okay. And the other are 4 embrasures in 4 directions. Your contact is bulging, okay, having occlusal embrasure, and underneath is gingival embrasure, buccal embrasure, lingual embrasure. Your contact is created by gut to be in the middle occlusobuccal, slightly shifted towards the buccal, okay, surface rather than the lingual. That means the lingual embrasure is wider than the buccal embrasure, okay, and this will result in food deflection during mastication towards the lingual much more than the buccal, which is beneficial for your mastication and your swallowing. This means that the food deflection to the dorsal surface of the tongue is much more higher than that to go for the buccal vestibule, and the tongue will rise it up to the occlusal surface and remasticate it until you could swallow it, okay. This is the idea. God created the contact at that position. Okay? You should examine your contact tightness, okay, which means to how much it is bulging to touch the neighboring tooth, okay, and examine its dimension. This could be done by waxed dental floss, okay, not unwaxed. Unwaxed may damage your contact, but waxed one, the wax itself is acting as a lubricant that ease the passage of your dental floss along the contact, okay. Then you could examine the tightness, okay, and the location of your contact. If the contact is open, then it is a disaster that will lead to food accumulation, that will impinge the gingival tissues, leading to its trauma, okay, creating periodontal pockets, and at the same time, it provides a great chance for recurrent caries. Not only recurrent caries in the tooth restored, but also may develop a new carious lesion in the proximal surface of neighboring one. Okay, that's why your restoration should be replaced. Okay, and mostly this problem is related to the thickness of your matrix band you choose. Okay, is not suitable. The wedge is loose, is not applied tightly, that will close the gingival portion and open, slightly open, to reproduce a positive contact with the neighboring tooth, or may be related to the condensation force. Whatever the cause, also may be due to early biting. You are not instructing your patient, or the patient is not following your instructions, okay, carefully, okay. Whatever the cause, but we have an open contact, then you should replace your restoration. In certain cases, we may have a controversial issue, which is extra tight contact. You are pushing your amalgam restoration, too much tight contact, okay? Your contact is over convex, that presses on the neighboring tooth. Also, your patient will suffer from food stagnation, but not subgingival at the contact area itself, because he couldn't clean it, okay? And he will record that he couldn't pass the dental floss. Not only that, okay, the teeth will start to be tender to percussion, especially the neighboring one. You will discover that your patient not only discovering from tenderness from the restored tooth, the tooth you have been restored, but also from the neighboring one, because you are pressing on it for a long time, okay? Both of them, either tight or open contact, will result in gingival and periodontal problems and should be replaced. For tight, extra tight contact, you may use any finishing strips if you could, but it will not succeed. It couldn't succeed in all cases. It's not, don't take it for granted that it will succeed. It's better to replace your restoration, okay? Sometimes your problem was inadequate embrasure. What is meant by inadequate embrasure? You are changing the location of your contact area. That's why, okay, as a proximal contact, okay, this prevents proper flossing. This allowed for food stagnation, lingual or buccal, most probably more buccal, because you shifted the contact area from to be shifted slightly buccal, you shifted it to be slightly lingual. Okay, this means that you increase the dimensions of the buccal embrasure that could not tolerate the extra food that is impinged or stagnated buccally. Okay, those are different types of contact. Okay, A and B showing open proximal contact, and you could note for the figure B the developed proximal caries in the neighboring distal surface of the premolar. Okay, for C and D, it's a very tight one. Okay, extra tight contact. Okay, you could note for C the operator is altering the embrasures, buccal and palatal embrasures. For D, you could note the inflammation of the interdental papillae. Okay. For E and F, those are proper contact reproduction. Okay, in dimensions and in tightness. Okay, improper occlusal contacts means that either you overcarved or undercarved your restoration. Overcarved means that you are reducing too much of your occlusal anatomy. That's why the patient will come to you suffer from food accumulations that could not be chewed in the center of your amalgam restorations. This means that you are under occlusion. Okay, some operators in certain cases prefer to make the amalgam, especially if they are reproducing or restoring missing cusp, okay, with pins or with any other alternative retentive techniques, prefer to make amalgam out of occlusion. This is not an accurate solution, because they thought that amalgam is brittle material, and when it comes out of occlusion, then it will not be subjected to the brittle component of your occlusal, the tensile component that could break the brittle material, okay, under occlusal force. No, this is not right. This is just a time factor, okay, because your teeth, remember that your teeth is under continuous eruption by time, and that's why when you are extracting a tooth, this will lead to mesial drifting of the neighboring and sometimes over eruption of the opposing. When you are relieving your amalgam restoration or any brittle restoration to be out of occlusion, number one, you already missed one of the major objectives of your restorative treatment, and at the same time you didn't fulfill the patient needs. The patient didn't understand that this is amalgam and it's brittle and could be fracture under tensile force. The patient only needs to have a functioning tooth. Then if you overcarved it, for him it's non-functioning. You didn't fulfill his needs. You didn't fulfill your objectives. And at the same time, okay, it's just a matter of time, your tooth, by eruptive force, many studies say that it will adapt itself to reach occlusion. And at the same time, you may endanger the TMJ of your patient, because he will develop an eccentric occlusal habits or parafunctional habit in a trial to functioning at this tooth. This is a wrong concept. That's why if your restoration is overcarved, okay, and not flushed with the cusp inclined plane at the same level, then you are in need to replace it. But most commonly is the undercarved one. Undercarved one because either the operator consumed all the working time of amalgam restoration without finishing his carving, at that for the picture in the left, and it is a flat one, okay, and he may depend on the next day or the next visit for finishing and polishing to recreate the anatomy. But what if the patient didn't come to you again? Okay, he may either thought the defect is you, or he may thought it is functioning well and this is the right thing. But by time, this will create premature contacts that will concentrate the occlusal force on this premature occlusal contact area. That by time, okay, and soonly will the patient will feel tenderness and pain, and he could not bite because you're already overloading your periodontal fibers and your bone, and it may by time induce mobility of the tooth, and the tooth become tender. That's why you should either replace the amalgam, or at least in certain minor cases, okay, you should check the occlusion, finish and polish your restoration, okay. You are not in all cases in need to replace your amalgam. The second case is the right one when the case is a complicated or a complex amalgam restoration that needs extra time, you are here, okay, in a fight with time. You are fighting the working time, okay? And that's why in most of these cases, as you could note in the photo to the right one, okay, you may leave a premature contact because amalgam starts to crystallize and initial setting started. That's why you are not able to adjust the occlusal contacts, but you should instruct your patient at this time, okay? Then when the patient suffering from such a problem and you discover it, to determine the extent of the problem, either number one, clinical investigation will reveal, as you see, a shiny area in your amalgam, revealing that it is high contact this is the first point which touches the adjacent or the opposing teeth. Firstly, that's why it is polished, okay, and seems to be shiny facet, okay. But if it does not appear, you shouldn't depend on this shiny facet to appear, but you should use articulating paper to determine the extent of problem. Finishing and polishing will solve this problem for the patient. One of the other problems is marginal ridge incompatibility, and this mainly is due to either it appears early due to neglection of carving occlusal embrasure with explorer, okay, before removing your matrix band, and at this time the operator is lucky because the amalgam is not broken at the contact area when he getting out his matrix band, okay, or an older restoration going flow and creep, okay, which a time-dependent deformation that destroyed the anatomical form of your amalgam restoration. In such a condition, the patient will suffer from what is called scissor contact or scissor marginal ridge that attracts fibers like a scissor at the marginal ridge itself, okay. Most probably, if you concentrate on the distal surface of the premolar, this creates by time caries in the neighboring tooth, and the only solution is to replace your restoration. Finally, recurrent caries, okay, which appears at the marginal area of restoration, detected visually, tactile, radiographically, the same as that for initial caries lesion or primary caries lesion, and by all means there is no mean of repair of such restoration. Either it is amalgam, composite, GIC, gold, whatever the type of restoration. Recurrent caries needs to totally remove your restoration, evaluate the case, excavate the caries, and re-indicate the suitable technique and the suitable material for the case according to the remaining tooth structure and the type of occlusion. Okay, let us go for this exercise. Okay, let us evaluate those amalgam restorations of those teeth. Let us start with tooth number 2-4. You could note in tooth 2-4 that marginal ditching is obvious along the whole margins, okay? Even at the occlusobuccal line angle, you could note at this corner a marginal ditching of a tooth and a marginal ditching of amalgam of both of them, but it is clear at the tooth because of improper finishing of cavo surface margin to be 90 degrees at this area. Also, gross marginal ditching at the palatal walls of the proximal cavity, at the same time improper proximal contact and neglection of occlusal embrasure. You could note also the marginal ridge is not accurate, okay. For tooth number 2-5, it is the same marginal ditching along the cavo surface angle, amalgam blues, okay, or maybe recurrent caries, okay. It seems to be amalgam blues, okay, towards the buccal and lingual walls of the occlusal surface, okay, but due to ditching marginal ditching at this area. We are not sure if it is blues or it is caries because already we have an open margin, and most probably from my opinion it is a recurrent caries. Also improper proximal contact. For the tooth number 26 are the same, okay, in all, okay, in addition to amalgam blues or recurrent caries at the buccal surface, and in addition to improximal contact and neglection of occlusal embrasure also, which leads to incompatibility of marginal ridge. But another added thing here is we have a fracture line, isthmus fracture at the junction or isthmus junction between the occlusal and the palatal extension. For this tooth, it seems to be a nice, perfect amalgam restoration. Okay, but if you magnifying or concentrate in certain areas, okay, what about this area? This area showing marginal flashes, okay, outside the boundaries of the cavity, okay, and mostly it is within, okay, the supplemental grooves. This is expected. That's why you should clarify your supplemental grooves of amalgam by fine-tipped explorer to avoid any remnants of amalgam in these coalesced or supplemental grooves that will lead to these marginal flashes. Okay, when subjected to force, it's easily to be fractured. Another one, but in advanced stage, which is marginal ditching. It seems all of these seems to be marginal flashes because it is related to the same supplemental groups of other cusps, okay, that fractured by time, okay, and also other margins, all other margins are clear, all other margins are well constructed, especially contact area, okay, and the reproduction of proximal anatomy. Let us examine another tooth showing this discoloration around the margins. Okay, here comes a very critical question. Is this a recurrent caries, or should I consider it as amalgam blues? Number one, you should examine the color. Okay, the color of caries tends to be brownish, but for amalgam blues, it's a bluish metallic color. Okay, this is number one. Okay, and you could inspect it under magnification. Number two, the margins. Okay, if the margins are well adapted, like that in our clinical photograph, okay, then it is most probably amalgam blues. Because if it is a recurrent caries, okay, and starting at this and the margins are well adapted like this, okay, I doubt it is a recurrent caries. For recurrent caries, either the margins is opened or the restoration is not stabilized because of the extension of caries at the pulpal floor. If it is a remnant of caries, okay, the restoration will not be retained in its place. Okay, then comes the caries index and the caries risk assessment. Okay, for the patient indicates or prefer one of them rather than the other. Okay, if the caries index is high and the oral hygiene is bad, which is not the condition in our case here, okay, then the upper or most probably, okay, it will be a recurrent caries. Then bite wing radiograph, okay, is the final, okay, that will exactly determine if it is a recurrent caries or it is amalgam blues. Amalgam blues, due to corrosive products, okay, appears radio opaque, as we discussed before, while recurrent caries appears radiolucent. Okay, then comes tooth colored restoration. Tooth colored restoration, either direct or indirect, it is similarly evaluated to that of amalgam restoration, except for additional one, okay, which is the aesthetics, because mostly patient requires two-scalloped restoration either for posterior or anterior, okay, for the purpose of aesthetic. Then you could examine discoloration, okay, of your restoration. And discoloration, either it is marginal, surface, or bulk discoloration. And these photographs for case A and B, okay, your restoration having a bulk discoloration. This bulk discoloration either due to misselection of the original shade of your case, or due to patient habits, and you are selecting, or the restoration was of poor quality material, okay, or poor quality manipulation. Okay, that's why with the patient habits like smoking, excessive drinking of tea, and excessive drinking of stained drinks and beverages, okay, then in such a case you are in need to replace your restoration. For case C, it shows a surface discoloration. Okay, surface discoloration may be the error in the last layer, or maybe due to your patient habits. Okay, try number one to finish and polish your restoration. Okay, very well, this discoloration may be removed. Okay, or sometimes you are in need to resurface this layer by just removing a very thin layer from your direct restoration and replace it for a new one. But for me, I hate to repair composite resin unless it is in the same visit and I didn't remove my rubber dam. Okay, I could repair it immediately. Otherwise, your free radicals are consumed. That's why the bond between the new layer and the old layer will not be the same. Okay, and it is better. Also, I didn't know what is the brand name of the material used, okay, and what is the brand of the material I will use, okay. This also affects the shading, okay, affects what is the quality of your restoration before you repair it, okay. I prefer also to replace it, okay, because most of cases of repaired, in many systematic reviews mentioned that most of cases of repaired composite resin restoration will be fated to be also replaced sooner or later. That's why it is better to replace it from the beginning. But if you have a marginal discoloration at the like the photo D, okay, at the margins, okay, obviously this is a micro leakage. Obviously, there is a problem in your bonding procedure from A to Z, either from isolation, application of etching, selection of bonding material, applying the material in multi-coats, whatever the error, but finally it's a gross leakage. And if you ask your patient about the history of this restoration, you will discover that he was suffering from sensitivity, or maybe still suffering from sensitivity, okay, after immediate restoring his teeth with this restoration. And this discoloration, marginal discoloration, we hope it is only discoloration and not extended up to you find a recurrent caries under your composite. So by all means, once your patient is complaining from post-operative hypersensitivity after placing composite resin or discoloration at the margin, okay, you should replace your composite because there is an error in your bonding procedure. Finally, indirect restorations. Indirect restoration are also either metallic or non-metallic, should be examined like that of amalgam, and if it is indirect two-scalloped restoration, should add the same as composite examination, should add the item of discoloration, but also stability of restoration. It is not rocking in your cavity, okay, should be examined. If such a rocking appears or the restoration seems to be unstable in its place, then that means that there is a breakdown in your cement line, okay, whatever it is, resin modified resin cement, okay, dual cured resin cement, or it is conventional cement for indirect metallic restoration, okay, that means that your adaptation is violated and there is a risk of recurrent caries, and the restoration should be removed from the cavity, cleaned from the cement, okay? Check the cavity and examine it again. Check the adaptability of your restoration. Check the wall divergency, okay, if it is proper or over, and re-cement it, or you may modify the cavity and replace it. Finally, as usual, those are the textbooks I used, okay, or I depend on preparing my presentation. If you would like to review something or have extra readings, I suggest those. Finally, please feel free to ask me, as your questions are welcomed all the time. You could reply, or you could comment for your inquiry to this video, and I will reply to you as soon as possible. Or you could contact me according to my contact info. Please don't forget to subscribe to my channel, activate notification, and like this video if you would like to get all the updates of my topics. Finally, I would like to thank you for assigning this time to listen to me, Yasser Al-Wasifi.